So welcome everybody to the ATI seminar series. I'm Kieran Halloran. I'm going to be moderating today. I'd first just like to start with an acknowledgement that the University of Alberta acknowledges we're located on Treaty 6 territory, and we respect the histories, languages, and cultures of First Nations, Métis, Inuit, and all First Peoples of Canada. And I'd also like to thank Paladin for their ongoing support of the seminar series. So today's speaker will be Dr. Alim Hirji. He's a friend and colleague of mine, and he's an associate professor and respirologist in the DOM here at the U of A. He received his Doctor of Medicine from McMaster University, completed his internal medicine training at the University of Toronto, and then his pulmonary medicine fellowship through the University of British Columbia, and then completed a fellowship in lung transplantation in the Toronto Lung Transplant Program. So he's really managed to see almost the entirety of Canada over the course of his training, and work with many different groups, which is a huge asset. He then went on to obtain a master's in epidemiology through the London School of Hygiene and Tropical Medicine through the UK. In addition to his research efforts, he's also the current chair of the lung section for the Canadian Society of Transplantation. So he'll be talking to us today about pre-transplant malignancy and factoring cancer risk into transplant candidacy assessments and the development of post-transplant malignancy, which I know is a topic that's always challenging for us and somewhat nebulous in recommendations. So I think everybody will appreciate some additional clarity on this. I think it'll be a great topic. So please take it away, Alim.
Thanks to the ATI for the opportunity to speak today and to share some of the recent work that we've done. And so today we're going to talk about cancer, and with a focus on pre-transplant malignancy. And whenever we talk about cancer, the conversation is usually deeply rooted in a discussion surrounding the concept of risk. And especially when it comes to management of cancer, you ask, should I get that prostatectomy for prostate cancer? What's the risk of progression? Should I have adjuvant therapy, chemotherapy after a mastectomy? What is the risk of recurrence? And so specifically, in terms of management, we talk a lot about risk and considerations of prognosis. And when we look at malignancy from the lens of transplantation, there is a whole other layer of risk that we need to consider. We ask the questions when we're assessing a potential candidate is, what is the additional risk of recurrence for a patient who will be on immunosuppression? What is the additional risk of cancer overall in someone who will be immunosuppressed? How are we going to change our immunosuppressive regimen potentially for this patient? And what is the risk to the graft? And how do we mitigate risk based on how we're going to monitor these patients after transplant in terms of surveillance? And so these are some of the concepts that we're going to talk about today. And I think it'll lead to some good discussion. As I like to say, I don't have anything interesting to disclose. And what I'm hoping that we'll be able to accomplish through the course of this talk is that understand the correlation between pre-transplant malignancy and the risk of development of post-transplant malignancy. We're going to spend a few slides reviewing recent consensus guidelines on pre-transplant malignancy and transplant candidacy. And many of the clinicians may have seen these guidelines, and I think they're very helpful to look at because it's helpful information when you're assessing a patient for transplantation who's had a malignancy in the past. But it also gives you a sense of how the perception of malignancy is evolving over time. And so we'll look a little bit further into that. And then we'll discuss appropriate strategies for cancer screening post-transplantation, including those who've had cancer before. So I'll start with this fact. There's over 1.5 million people in Canada who either have cancer or have had cancer at this very moment. And I was just Wikipediaing it, and I think the population in Canada is 38 million now, with 31 million adults. So this is about 5% of the population. And it's estimated in this year, over 230,000 Canadians will be diagnosed with cancer. and 85,000 Canadians will die of cancer. Okay, so these are significant numbers. And I think this next fact is really, I think, which is really mind-boggling to me, is that 2 in 5 Canadians are expected to develop cancer during their lifetime. Okay, and I think that really is an indication of the extent to which cancer is impacting our society and how it's really becoming a relevant factor in all aspects of clinical care, including transplantation. So as you probably have a sense, the most common cancer in terms of prevalence in our country is breast cancer, followed by prostate cancer, and then after that colorectal, and then several other different cancers, melanoma, thyroid, bladder, lymphoma, uterus, and lung. And if we look at prevalence across the country, there's significant prevalence of cancer throughout all the provinces. You can see here that there's a slight increase, higher prevalence of malignancy in the East Coast. And here it actually demonstrates that Alberta actually has a little bit of lower prevalence of cancer compared to our neighbors. Now, does that mean that Albertans are less likely to develop cancer? Does that mean that we're not as good at detecting cancer? Does that mean that we don't live as long and don't have the opportunity to develop cancer? I don't know the answer to that. But I think what we can gather from this is that the prevalence of cancer across the country is significant. And if you look at this chart here on the right-hand side, you can see that about 40% of all people who have or have had cancer have developed it within the past 5 years. And that's significant when it comes to transplant. And so, there's a lot of prevalence across the country and of cancer, and it's inevitable that at some point, a proportion of those people are going to require a transplant for whatever organ it is. And as stewards of really a scarce resource, we have a responsibility as transplant clinicians to ensure that we're allocating organs based on the principles of utility, justice, and respect for persons. And the first principle, the principle of utility, really dictates that we should be allocating organs to those who can maximize the benefit from those organs. And if someone has a history of malignancy, then that can definitely have an impact in terms of outcomes. But it's a big responsibility, and it's one that you have to take seriously, because this is really just to give you a view of what the landscape is. And this is US data, but Canadian data really reflects this very similarly, in that this line is the number of people who need a transplant, and these bars are the number of organs we have to work with. And you can just see the vast difference between that. And so, and I can tell you that COVID really hasn't helped us at all. And this is CBS data about lung transplants being performed across Canada. And you can see that the numbers were going up and up. And since the pandemic has hit, there's been a significant reduction in the number of transplants across the country that have been performed. And this is primarily because of a reduction in the number of donor offers that we've received. And so further exacerbates an already significant issue. And just to have you appreciate how much of a problem this is core data looking at lung transplant waitlist registrations. And so you can see, in 2020, there was 165 people who were waitlisted for a lung transplant, and 31 people on the transplant list died that year. And that's about 20% of people who are waitlisted. And so, 1 in 5 people who are waiting for a lung transplant will never get it and will die waiting for it. And so we have to ensure that we are using these organs in the best possible way to maximize utility. And what we used to do, and I think about when I started training for lung transplant 10 years ago, is that what we were taught is that if someone has cancer, 5 years, no transplant, right? And this is data, this is actually a meta-analysis from the Toronto Renal Transplant Group, where they looked at TCT, and TCT is time from cancer to transplant. And it indicated that if you were more than 5 years from your cancer to your transplant, you had less likelihood of development of recurrence after your transplant, right? And that makes sense. The issue with this, however, is that it's really lumping all cancers into one pot. And we know that cancers are all different, and that in some cancer fields, there's been significant advancements in terms of therapies, in terms of prognosis, and that we really can't put all cancer into one pot and say that, you know, we can't transplant you for 5 years, because the majority of people who are coming to be listed for transplant don't have 5 years to wait. And so this evolution of thinking and understanding is, I think, really being seen primarily in the guidelines. And so what I wanted to share with you was, this is our ISHLT consensus document for a selection of lung transplant candidates, and gives us guidance on, you know, who we deem to be an appropriate candidate or not. And on the left is our 2014 guidelines, and then on the right is the 2021 guidelines. And you can see back in 2015, which is, you know, not that long ago, the verbiage around malignancy was very strong. And you can see it's under absolute contraindication. It says lung transplantation should not be offered to adults with a recent history of malignancy, and that a 5-year disease-free interval is prudent in most cases. And they list those, and it's almost all the different types of cancers. Now, fast forward only about 6 years, and you can see that there is an understanding that not all cancers are the same, and that the most recent guidelines say that malignancy with high risk of recurrence or death is an absolute contraindication, but is increasingly acknowledged in the context of lung transplant that not all neoplastic diseases are equal. Certain malignancies may not be significantly affected by immunosuppression, and some may be managed post-transplant with aggressive surveillance and intervention. And it goes on to say, and I think this is the most realistic part of having a consensus guideline like this, is that transplant centers should work closely with oncology specialists to evaluate each patient with a history of cancer to determine the stage-specific risk of recurrence or progression, and to determine the necessary cancer-free period prior to listing. Okay, and so there is no more blanket statement and more of an understanding that cancer is not one homogeneous diagnosis with a static risk, and that it's variable, and really things need to be looked at on a case-by-case basis. And I think with the understanding of this is actually a recent publication in Circulation Heart Failure, looking at the impact of pre-transplant malignancy on heart transplant outcomes. And you can see here in the bottom graph that the percentage of centers transplanting recipients with a history of pre-transplant malignancy is going up, as there's more comfort and there's more of an interaction with oncologists, and more of a comfort in terms of listing these patients with appropriate follow-up after transplant. And you can see linked to that is that there's an increase in the percentage of heart transplant recipients that have a history of pre-transplant malignancy. And that's part of an aging population, but that's also part of understanding that there is an acceptance that there is variability within malignancy. And so this is really moving towards a personalized approach on candidacy, where we can think of more factors, and this actually opens up a lot more factors to consider than just cancer factors. And so now we start to think, okay, you know, how long has it been since your cancer? What was the extent of it? What was the disease biology? What was the stage? What's the likelihood of this cancer to recur? We look at immunosuppression factors. So, you know, what type of transplant do you need? What kind of immunosuppression are you going to need, and levels of that, and how does that immunosuppression affect that cancer's recurrence? And then on top of that, now there's a whole door being open in terms of considering patient factors as well. Is this a transplant to save a life, or is this for quality of life? Are there modifiable or non-modifiable risk factors, whether that's genetics, whether it's reduction of smoking or metabolic disease? And so all these factors can come into play. And it's essential to consider all of this, because let me be clear, the issue of post-transplant malignancy is a huge one. And this is a paper looking at cumulative tumor incidence in renal transplantation. And the data is a little bit old, but it's still reflective of what's happening now. And you can see, and I like just how it's depicted here, is that the dotted line is an age-adjusted normal population in terms of risk of malignancy over time. And you can see that the solid line is the risk of cancer in the post-transplant population. And you know, at 10 years after transplant, 1 in 5 patients will have developed a malignancy. And if you're lucky enough to live 25 years after your transplant, the chances are 1 in 2 that a transplant recipient will develop a malignancy of some sort. Okay, and that's very relevant. And if we look at all organ transplant groups, not just the kidney group, this is it was published in JAMA about 10 years ago, and they looked at the UNOS registry of over 175,000 solid organ transplants, and they found that the overall risk of developing cancer in a transplanted patient is twice that, so the standard incidence ratio of 2.1 compared to the general population. And that's just looking at overall cancer risk. What's interesting is that there's specific cancers which are much more than twice that of the general population. They're 60 times that of the general population. And so if you look at Kaposi sarcoma, development of non-melanoma skin cancer, lymphoma, kidney cancer, anal cancers, they're significantly elevated compared to the general population. And what's interesting in the right graph here, this is standardized mortality ratio, is that the most common cancers aren't really the ones that actually lead to increased mortality post-transplant. Where it's the PTLD, it's kidney cancers, it's melanoma. Those are the ones that are actually contributing to higher rates of death after transplantation. And what's I think relevant is that the increased burden of malignancy that we see after transplant does equate to worse survival. And this is looking specifically at lung transplant patients using the UNOS database. And you can see that the dotted line here, which is patients who develop a de novo malignancy post-transplant, you can see the survival is worse as time goes on compared to patients who did not develop malignancy. And so it's important for us understanding that the development of malignancy after transplant has significant impact on survival outcomes that we need to be able to decide upfront who is an appropriate candidate or not, considering the risk of the malignancy that they've had. And it's not an easy thing to do, as Kieran had initially mentioned, and that's why it's so important for us to have some sort of guidelines to go by. And this is a consensus expert opinion statement from through the American Journal of Transplantation that was just published at the end of last year that looks at pre-transplant solid organ malignancy and recommendations on organ transplant candidacy. And I'm just going to take about 5 slides to go through the most common cancers, just so that we can, just so you can understand sort of what the current recommendations are, as well as have an understanding of how things have evolved over time and kind of what's recommended. And I'll tell you, when I first read this consensus guideline, I was actually quite surprised by some of the recommendations. And so if we look at breast cancer, it says here that if you're low risk, so you have DCIS or you have stage 1 breast cancer, once you have received standard treatment, you don't have to wait any longer and can be listed for be considered for transplant. If you're a stage 2 breast cancer, you should wait 1 to 2 years with no evidence of disease. Stage 3 should be 3 to 5 years with no evidence of disease. And if you have stage 4, which is metastatic breast cancer, then you're not a transplant candidate. And there are some caveats in terms of what your hormone receptor status is or whatnot. But to see that a stage 1 breast cancer after appropriate treatment can go ahead right away I think is a shift in terms of what's been recommended in the past. And an important point here at the bottom is that endocrine therapy does not need to be completed prior to transplant. And we've seen this in our lung transplant cohort as well. We have people who are on tamoxifen and anastrozole, and that it's fairly well tolerated. There's few serious side effects. That's not considered part of active therapy and can be continued concomitantly on post-transplant. When we look at colon cancer, it's a little bit more strict here. If you have a stage 1 cancer, and this is after receiving appropriate treatment for the malignancy, time to interval to transplant is 1 year. If you have a stage 2, 2 years. If you are high risk, so stage 2 high risk, or you have stage 3, which is nodal involvement, you have to wait 3 years, maybe 5 years if you have high risk features which are present, and the high risk features are listed here on the side. And if you're stage 4 colon cancer, which includes metastases, they say that if you can demonstrate 5 years of no evidence of disease, then can consider transplantation. But again, these are very high risk individuals. So again, stricter than breast cancer. Prostate cancer is where I was really surprised to see what the recommendations are. And you can see if you're very low risk or low risk, you don't even need to have completed therapy. There is no wait time to move forward with transplant. It's felt that the risk of metastases and of death over the ensuing 15 years is so low that you can progress and can continue to monitor these patients and treat them if necessary after transplant. Even if you look at intermediate risk or even very high risk individuals with prostate cancer, this is high Gleason scores of PSA over 20. If you can predict that the cancer-specific death over the next 15 years is less than 10% based on biology, there is no wait time to move forward with transplant. Even if you have metastatic disease, which is responsive to anti-androgen therapy, and you can demonstrate stability of disease for over 2 years, there's a recommendation that you can still move forward with transplant. So this is a lot more lax than what I had seen in the past, and again, it's based on evidence and risk of prognosis and metastasis based on different stages here. If we look at gynecological cancer, it sort of follows the same format that it's based on risk. And so if your risk of recurrence is low, less than 5%, there's no waiting period after you've completed primary treatment. If you have intermediate risk, you should wait 2 to 3 years after treatment. If you have high risk of recurrence greater than 30%, you should wait 5 years after completion of treatment. And if you have very high risk, then that's the situation where you're not considered a transplant candidate in the future. And again, these are conversations that you have with oncologists and with gynecology as well. And then lung cancer continues, because of the poor prognosis associated with lung cancer, continues to be the most strict, in that really, if you have stage 1 lung cancer, which is resectable, you should still wait more than 3 years before moving forward to transplant. If you have T1, stage 1 T1 disease, so you should be waiting up to 5 years. And anything really that's stage 2 and beyond, you have to be waiting 5 years. If you have any nodal involvement, so you're stage 3, or you have metastatic disease and non-transplant candidate, that really hasn't changed much. And I think that's just because the prognosis of lung cancer still remains quite poor. But I think these guidelines really do show you that there's a demonstration of the appreciation of the variability of malignancy, and that we can now start looking at cancer factors, but take that into consideration and then consider all the other components that help us decide when we are moving forward to transplant someone who's had a history of cancer before. And I'm going to share with you a case, and this is a case that our lung group knows really well, that has really helped me to appreciate the importance of having a multi-dimensional, looking at cancer from a multi-dimensional view. And so this is a gentleman who was 33 when he was diagnosed with pulmonary fibrosis in 2012. And being very young, he had a lung biopsy in 2013, which demonstrated UIP fibrosis. And he had some dyspnea, and that dyspnea progressed in 2018. And so he had undergone a bronchoscopy at that time. It had biopsies done of the right lower lobe, given his imaging looking like this, which demonstrated chronic interstitial fibrosis, which is in keeping with his diagnosis of pulmonary fibrosis. And later that year, he developed worsening dyspnea, developed hypoxemia, and eventually required ECMO support to maintain his oxygen levels. And we had urgently worked him up for a transplant, and it took almost about a month, I believe, before we were able to find him an appropriate donor. And he got transplanted and actually had a really smooth recovery perioperatively. He was extubated early. His X-ray looked fantastic afterwards, and the family was so thrilled, and the lung group was kind of high fives all around. And then we get a call from the pathologist who's just reviewed the explants and says the finding here is bilateral pulmonary adenocarcinoma, and if you look here, with multiple lymph nodes which are positive. And this was not detected on the biopsy, which was done just months before, and so wasn't something that we were aware of until afterwards. And so we had to break this to the patient, and it was obviously very devastating. And what do you do in a situation like this? And so we moved ahead with treatment, working with Quincy Chu from the Cross Cancer Institute, gave him 4 cycles of adjuvant chemotherapy. And it was difficult for him to tolerate, but then he recovered. And about 18 months after he received his chemotherapy, he started developing pulmonary nodules. And so he had a batch biopsy done in September 2021, and that showed multicentric pulmonary adenocarcinoma, so recurrence of the disease, right? And that's not a surprise, knowing what we know about the risk of recurrence in someone who goes into transplant with active malignancy. And so we've been treating him with intermittent pemetrexed. We've actually had to hold his mycophenolate because of pancytopenia, and it's usually our approach if someone is receiving sort of more standard chemotherapy. And, you know, in the books, this is a failure, right? Early recurrence of malignancy, need for chemotherapy, interruption of immunosuppression in a patient with some impact in his lung function. But when I was in clinic with him last, he told me, he said, you know what, Dr. Hirji, I am so thankful that you didn't know I had cancer when I was transplanted. And he goes, you know I've had to go through chemo, but over the past 4 years, I've been able to work. I've been able to do the things that I love, provide for my family. I've seen my daughters, become teenagers. And it has really challenged my framework of what we consider a successful outcome. And that's why I think it's so important that when we're having these conversations about cancer, that we are considering patient factors and all the other components of it, and just saying, sorry, you have cancer, 5 years, no transplant for you. And this is a very extreme example, but just I think speaks to the importance of looking at several factors and considering that. And so, this was a blatant occurrence of malignancy recurrence after transplant. But around the same time, in clinic, we were also seeing a lot of people who had a history of pre-transplant malignancy who were developing different cancers. And so Victor Sikowski, who's a pulmonary fellow in our division right now, and myself, we actually we asked the question, if you've had a malignancy pre-transplant, is that associated with recurrence, or is that associated with the risk of developing a cancer after transplant? And this hadn't been looked at specifically in lung transplant. And so we performed a retrospective chart review, and this was published in the summer this year, where we looked at adult lung transplant recipients between 2006 and 2017. You can see we had a study cohort of 497 patients who were transplanted during that period. And the median follow-up for these patients was about 4 years and extending up to 13 years. And the median time from pre-transplant malignancy to transplant was about 5 years, given that we do follow guidelines. And so that's really in keeping with that. And what we found is that, so we had 28 patients who had a history of malignancy prior to transplant. And if, based on the size of this cohort, that's about 5%, which is in keeping with other studies. And when we looked at those who had a history of malignancy prior to transplant compared to those who had not had malignancy prior, the significant differences were that this was an older population, right? So they've had more time to accrue the likelihood of malignancy, and we know that malignancy risk is higher as you age. They are more likely to have a diagnosis of COPD or pulmonary fibrosis, and less likely to have bronchiectasis or pulmonary hypertension. Again, that's partially due to age and partially due to the fact that smoking is a significant contributor to COPD, as well as to the risk of malignancy. And again, as you can see here, that the more smoking history that a patient had, the higher the risk that they had a malignancy prior to transplant. And what we found looking at this cohort is that we had 108 patients who had developed malignancy post-transplant. And this is for a total number of 328 cancers. And you can see here the majority of these were cutaneous, 87% of them, but there was about 8% that had solid organ malignancies. And when we look at people, and when we split up these two groups and we look at those who developed a malignancy after transplant, it was 20% of those who had never had a malignancy prior to transplant, and 45% of those who had had a malignancy before. And this was significantly different. And we saw that this was relevant for both solid organ malignancies as well as cutaneous malignancies. Where we didn't see a difference was in PTLD. And I think that's because PTLD is probably more likely dependent on EBV serology at the time of transplant and mismatch and degree of immunosuppression than it does have anything to do with history of pre-transplant malignancy. But when we actually did, our Cox regression here, we could see an adjusted hazard ratio, and this is adjusting for several risk factors for cancer, that are known, as well as that were detected in our initial analysis. You can see that the risk of developing a malignancy, if you've had a pre-transplant malignancy, was 3 times that of patients who had not had malignancy. And graphically, you can see here that there was quite a difference in terms of malignancy-free time between those who had a pre-transplant malignancy and those who had not. And what's really interesting here is that these are the diagnoses of pre-transplant malignancy in the cohort of those 28 patients. And you can see that it ranges from prostate cancer to basal cell carcinoma, breast cancer, bladder cancer, leukemia. There were only 3 patients that actually had recurrence of their malignancy after transplant. And so the majority of these patients actually had no recurrence. And even though there's an association with a higher development of malignancy after transplant, it wasn't due to their initial cancer in most situations. Okay. And so what our study conclusions were is that the history of pre-transplant malignancy is associated with a more than 3 times likelihood of development of post-transplant malignancy compared to those who had never had a history of cancer. That the majority of post-transplant malignancies were unrelated to the initial malignancy. And it's really highlighted the importance of frequent cancer surveillance in lung transplant recipients, and maybe more so in patients who've had a pre-transplant malignancy. And this was looking at a lung population, but there was a meta-analysis that looked at all solid organ transplant recipients in transplantation in 2017, and they came to very similar conclusions, which said that if you had had a pre-transplant malignancy, there was a higher risk of the development of de novo malignancy, and this is any type of malignancy. There is a higher risk of cancer-specific mortality, and there is a higher risk of all-cause mortality if you look at these forest plots. Really in keeping with what we found in our lung. And I just want to take sort of a moment to highlight that there are special circumstances, and we have to appreciate that there are different situations that can lead to the development of post-transplant malignancy that are not related to what we're talking about here, and that are kind of special circumstances. And so this is when we are transplanting for malignancy, and so as a therapy for malignancy, when there's residual risk of cancer after transplant, and when there's risk of cancer from the donor. Okay, and so these are sort of different situations where you can get cancer after transplant that are not associated with this risk that we've been talking about. And I'll just talk really briefly about each of these. We know that liver transplant is a therapy for cure of hepatocellular carcinoma. However, the risk associated with recurrence is significantly different than someone who has just had a pre-transplant malignancy in the past and has a risk of increased malignancy. And there's prediction models, such as this one, that using alpha-fetoprotein or microvascular invasion, or looking at tumor size that can help to determine what's the risk of recurrence of HCC after a liver transplant. And so this needs to be considered, and it's a different risk profile. When we look in the world of lung transplant, there's been several papers that have looked at the development of lung cancer after transplant and after lung transplant. And as you can see in this paper, that the majority of patients who develop lung cancer, it occurs in their native lung if they've had a single lung transplant. And in our program here in Edmonton, for the most part, we actually perform double lung transplants, but about 15% of lung transplants that are done across Canada each year are single lung transplants. And we have to appreciate that for indications like COPD, where there's significant smoking history, that there's a significantly elevated risk of developing malignancy in the native lung if it's left behind. And this has been shown in several studies as well. And then, as mentioned, there's also the consideration of donor transmission of cancer. And there's been several UNOS registry papers that have looked at this, and for the most part, that they indicate that there's no significant difference in post-transplant survival if you've used a donor that's had a history of malignancy versus not. But you have to appreciate that this is a very highly selected donor population, because those who have any significant risk of transmission have probably been declined. But despite that, there is an appreciation that there are certain malignancies that have a higher risk of transmission post-transplant, and melanoma is the highest on that list, lung, kidney, as you can see as well. And I actually read a case report a couple of days ago that a donor who had treated melanoma 32 years prior to the time of donation actually led to transmission post-transplant. And so there are definitely, there are definitely some malignancies that we have to consider continue to have a high risk of transmission risk. So this, brings us to the million-dollar question, which is, why does pre-transplant malignancy increase post-transplant malignancy risk? Especially, as we've shown in our paper, is that if it's not associated with recurrence. Okay, and I think to answer this, we really need to understand our immune system and how it functions in the face of cancer. And so this is a really nice pictorial of explaining, a host, sort of the process of immunosurveillance and how we use our immune system to monitor for malignancy. And so you can see that you have an immunocompetent host, they have normal cells, and then there's some sort of an insult which leads to the abnormal proliferation of those cells. So whether it's carcinogens, radiation, if it's chronic inflammation or viruses, and these abnormal cells then begin to actually produce their own tumor antigens, and that kicks up our immune system. And both the innate and adaptive immune systems, and specifically looking at our cytotoxic T cells, NK cells, macrophages, that they will descend upon these abnormal cells, and in most situations actually get rid of them, so this way that we have protection. And this is really the process of immunoediting, immunosurveillance. And there's certain cytokines which are released, and interferon gamma has actually been felt to be an essential player in the process of immunosurveillance. However, what happens in some situations, and this is if there's genetic instability or there's immune selection, is that there's some abnormal cells that can withstand the cleaning from our immune system and can stay prevalent. And in those situations, then they start to actually use components of the immune system. So looking at Tregs and other ways to actually use the immune system to defend against the immune system which is trying to attack them. And that can lead to escape into further proliferation of that tumor. And so that really kind of highlights how the immune system is used to protect ourselves from developing cancers frequently. And this was a really interesting study from more than 20 years ago, where lung cancer patients were actually assessed for their cytokine levels. And we looked at interferon gamma, which I said has a significant role in immunosurveillance, as well as IL-6, which is associated with chronic inflammation. And what was found was that lung cancer patients who had lower interferon gamma levels actually had a shorter survival, right? So their malignancy progressed faster. And if they had higher levels of IL-6, this was also associated with shorter survival, so because of the underlying chronic inflammation associated with it. So it tells you now that people have different degrees of immunity that they're able to keep in check malignancy. And so if you have someone who has already had a cancer and it may be predisposed based on their immunity, you guys all know this image, and what happens once we transplant someone, right? We use cyclosporin, tacrolimus, we use azathioprine, we use mycophenolate to impair the proliferation of T cells and further exacerbate what could be already a deficiency within our immune systems. And this is a really nice paper that was published in The Lancet, which looked at kidney transplant recipients. And they were looking at two different cyclosporin regimens. So one group getting standard cyclosporin troughs of kind of maintaining about 200 or so, and then another group which they were aiming for trough levels of 100. And what they were looking for in this study was there a difference in terms of incidence of cancer post-transplant based on these immunosuppressive regimens? And what they found is really, in keeping with what we've been talking about, is that those who were less immunosuppressed actually had a lower incidence of cancer post-transplant. And so this is an additive effect. The more immunosuppressed you are, the less likely that you're able to perform adequate immunosurveillance, and the higher the risk there is of the development of malignancy. This has also been shown in heart transplant recipients, looking at skin cancer development and the relevance of immunosuppressive therapy. And you can see that those who had a high rejection score, so those who had actually been treated for rejection, had a higher incidence of skin cancer after transplant. And it was because what was thought is that the augmented immunosuppression required increased the risk of malignancy. And so, we know that our immune system works to fight infection. Our macrophages get rid of virus-infected cells. Our T cells stimulate B cells to actually produce antibodies against viruses. Our killer T cells actually kill virus-infected cells as well. And so when we give immunosuppression, all of this goes down. And this is why we see so many different infectious causes of cancer. And you've all seen these, right? And they're very common infections that we see regularly. So H. pylori and its association with gastric carcinoma, hepatitis B and C and its association with liver cancer, human papillomavirus and its association with cervical, penile, anal, and vulvar carcinomas. We've seen such terrible head and neck cancers in our lung transplant population that require really disfiguring surgeries because of HPV. We've seen a significant number of patients develop PTLD due to EBV mismatch and proliferation of EBV. We've seen Kaposi sarcoma due to HHV8, T-cell leukemia related to HTLV1. These pathogens I'll leave for the hepatologist to pronounce. And then, schistosomiasis and its association with bladder cancer as well. And so, we know that infection can lead to cancer. And if you look at, the development of PTLD after transplant, which is associated with EBV, it's really that the higher the immunosuppression that you're using, the higher incidence there is of PTLD, right? And so lung first, then heart, then kidney, then liver. Lung first, then heart, then kidney, then liver. And this is what you see is that it's based on the degree of immunosuppression that we're using. And so, if you ask, why does infection lead to the development of malignancy? A lot of it has to do with persistent chronic inflammation in the host. And as you can see, microbial infections lead to chronic inflammation. And when you have chronic inflammation, that leads to impaired apoptosis, leads to the activation of growth-promoting oncogenes, the inactivation of tumor suppressors. And so really it deactivates the ability for immunosurveillance and really leads a lot of fodder for abnormal proliferation. However, not all malignancies that we see post-transplant are related to infection. Okay, and so there's more at play than just infection leads to cancer, and that's why we see increased malignancies, right? We see breast cancer, we see lung cancer, we see kidney cancers, and so sure, lymphocytes are the immunosuppression using calcineurin inhibitors is impaired, and that increases the risk of infections and the possibility of mutations. But we also know that using calcineurin inhibitors actually impairs the ability for a cell to perform DNA repair, as we've seen through immunosurveillance, right? And so there's a more likelihood of developing mutated cells. There's actually a less opportunity for apoptosis because of the use of calcineurin inhibitors. And so with that, we see less apoptosis and more mutations. Cancer cells actually, there's an association with calcineurin inhibitors and increased levels of TGF-beta, which can lead to more aggressive cancer cells. And I'll show you this here. This is, there's been animal models which suggest that cyclosporin promotes cancer progression by the increased production of TGF-beta. And this is a paper in transplantation which showed that the more tacrolimus that you use, the higher the expression of TGF-beta, which can lead to actually further proliferation of malignancies. There's also an elevated expression of VEGF, so vascular endothelial growth factors associated with CNIs, and that can lead to tumorigenesis. And it's not just calcineurin inhibitors, azathioprine, when it metabolizes into 6-thioguanine, can incorporate into the DNA and impair repair splicing. So, these immunosuppressants can lead to malignancy in other ways than just infection proliferation. And this is really to highlight that it's not just our immunosuppression, but other agents that we use post-transplant that are associated with cancer as well. And in the lung group, we use voriconazole as part of our antifungal prophylaxis in the first 3 months post-transplant, but it is well documented and published that voriconazole is associated with the development of cutaneous squamous cell carcinoma. And the older you are, if you've had skin cancer pre-transplant, the longer you're on voriconazole, the higher the risk there is of skin cancer. So it's not just our immunosuppression, it's also other agents that we're using as well. And so there's several factors that play into cancer susceptibility of a recipient. And part of it may be a not functioning surveillance system, right? So if there's already issues with your immune system, you may have infections that lead to chronic inflammation that can lead to progression of abnormal cells. There may be behaviors like significant smoking, or significant alcohol consumption, which can lead to increased risk of cancer. And so we really have to look at the individual as a whole to appreciate the different components that lead to cancer susceptibility and how that's exacerbated in someone who receives immunosuppression. And I think what's so important is that we have to remember that after someone is transplanted, that cancer susceptibility doesn't go away. It's only further exacerbated. And that's why it's so important that we are meticulous with cancer screening in our patients after transplant. And this was published just this year in the Clinical Journal of the American Society of Nephrology, and really goes through, the different recommendations for cancer screening for the different cancers post-kidney transplant. And this holds true in most transplant groups as well. So, for breast cancer, do screening mammographies in women 50 to 74, and prostate cancer we do PSAs in our program on an annual basis. And there's no question of over the age of 70, is there potential benefits of still looking for prostate cancer? And for cervical cancer, we have annual Pap tests done for our patients who are between the ages of 25 and 74. For bowel cancer, we do FIT tests every year. For lung cancer, they have chest x-rays done on an annual basis. These are recommendations about CT scans, and there is definitely evidence for this. However, Canada really hasn't necessarily adopted this because of sort of more logistical and infrastructure issues. But again, even EBV NAT monitoring for PTLD and whatnot. And so it's important to have all these components that we're continually monitoring in these patients. And I've asked myself, and someone who had a pre-transplant malignancy, what should we do different? How should we monitor these patients differently than all the other patients who haven't had a malignancy prior to transplant? And I think we follow the guidance from oncologists, and if they feel that we need to do something more frequently, we should. But I think what's more important is that so many times these cancer screening protocols get missed, right? And someone doesn't show up for their FIT test, or someone doesn't go for their mammography. And I think it's so much more important in patients who've had pre-transplant malignancy is to have a red flag in Connect Care or something that said, hey, we need to ensure that screening is being done and it's being done appropriately. And I think maybe that's the first step, and not too much of a difficult step, to ensure that we're providing appropriate monitoring. And it's important for us to keep up to date with what the Canadian guidelines are. And so, the Canadian Task Force on Preventative Healthcare have a website which lists all appropriate monitoring guidelines, regardless if it's cancer or if it's in abdominal aortic aneurysm. So I do recommend that if you're ever looking for screening guidelines, this is a great place to go. And so we have 10 minutes left, and so I'll just summarize by saying that patients with a history of pre-transplant malignancy do have an increased risk of developing post-transplant malignancy, okay, and that's not necessarily just due to recurrence. That decisions regarding transplant candidacy and those with a history of malignancy should be reviewed on a case-by-case basis, and consider not just if you have cancer, but cancer-specific factors, patient factors, and immunosuppression factors as well. And then I think it's really important that we ensure that protocols for cancer screening post-transplant are up to date and really allow for patient-specific surveillance, as we've just sort of discussed. And so I'll leave it at that. This is a picture of our lung group, which is a real privilege to work with this team. And I know you're all wondering, hey, where are you? Why aren't you in this picture? And unfortunately, I had COVID on the day that they had the picture taken, and I vowed that I would Photoshop myself into the picture, but I just haven't had a chance.
This was a wonderful, actually really comprehensive talk, much more comprehensive than I expected, and lots of room for discussion. So maybe I can lead off, and then there's at least one question in the chat, and if people are formulating their questions, feel free to put up your hand. So one thing that I've run into with these cases, Alim, is we reach out to the patient's oncologist for sort of consultative, risk assessment about post-transplant recurrence. And one thing that I've run into a little bit is that the oncologist is often then in a position a little bit of, being an arbiter of whether or not they get a transplant. And I think that they find that to be an awkward position. And I think that they don't want to be the person who shuts the door. And so they often end up being a bit of an advocate for their patient, and maybe it's a patient they've known for years, and so they'll sort of make sure that they phrase things carefully. And I never am sure if we're getting an objective evaluation in those situations. So I'm kind of wondering, when we talk about working with the oncologists to try and develop, some kind of risk assessment, how do we go about that? And should we be getting independent opinions? Should there be some kind of network of physicians? How should we navigate that?
Yeah, I've definitely, had similar experiences. And, I think what we have to do is that we shouldn't be posing the question as, should we transplant this patient? I think what they need to provide is a very objective measure of what is the risk of recurrence in this patient. And then that really speaks to, in that diagram where it shows the different factors when you're considering someone to transplant, is that they're only speaking to one part of it, which is, what's the cancer risk and the risk of recurrence. And that the whole decision, I think, has to be clear to them, is not resting on them, but there's several other factors that we need to consider, including immunosuppressive factors and patient factors. And that really just getting that number in terms of what's the risk of recurrence, because most people won't be able to tell you what's the risk of recurrence on immunosuppression, but they can maybe objectively tell you what's the prognosis in someone who has their stage of malignancy. And then that's just one piece of information that we take, looking at all the comorbidities and all the other factors that we have to consider. So I think it's primarily not resting the entire decision on them, just asking for that one point that they can speak to with knowledge.
Yeah, I was going to say that's the other big challenge is we're often given estimates of the recurrence risk in the general population and not necessarily, their experience in transplant patients may be non-existent or very limited. So, so that's another big challenge. Murray Wilson asked, how do you coordinate this detailed risk analysis with both the ICU and the ODO? It seems quite time intensive.
Yeah, that's a great question, Murray. And I think, these conversations that we have regarding candidacy in someone who's had a malignancy actually happen not in those forums. They're usually happening at our multidisciplinary discussions where we're talking about all the tests that we have available and all the information we have available about the patient. And so, the ICU and the ODO, ICUs and the ODOs are involved in the component where it comes to looking at the donor. But in terms of transplant recipients and considering their candidacy, a lot of that happens where we have maybe 30 people at the table looking at all the information that's available to us. And so I think it's hard, you're right, it would be very hard to coordinate with all those different groups. And I think that's why we have these dedicated meetings on a weekly basis to be able to review these difficult sort of situations and cases.
I was going to also ask about, biomarkers of post-transplant net state immunosuppression and whether or not there's utility to that in, predicting risk post-transplant. I know we use kind of more coarse biomarkers like, their age and things like that. But have we moved the needle at all on biomarkers of net state immunosuppression, specifically with the intent of post-transplant malignancy risk prediction?
I don't think so. I think that's the Holy Grail. I think we need it for so many different dimensions of transplant, right? And it still baffles me that for the most part we're giving an 18-year-old and a 70-year-old the same immunosuppression, right? Understanding immunosenescence and understanding risks of malignancy and infection and whatnot. And we really do need that barometer. And we've looked at different things like tortinovirus and other maybe potential cytokine markers. And I think we need to continue to do that. And you're right, that I think would have a big play in terms of looking at risk of malignancy after transplant.
And do you want to just, you've got your, I don't know if your microphone's working, and
yeah,
maybe you could just ask your question.
I think it's working. Can you hear me?
Yeah, we can hear you.
I was just wondering, and maybe I missed it because I got a phone call from my mom's pharmacy partway through your talk, so hopefully I did just miss this. But the living donation, like cancer detected in living donors later, I don't know if that's captured in our Canadian Transplant Registry or not right now. And maybe that's not fair to ask you because it's not a ton of lungs certainly for living donors, and I don't think they're in CTR. But do you think that matters? Like, is that something important to capture, or maybe that is a completely different thing?
So this is detected in living.
Like a living donor who goes on to develop cancer later. Is that
Yes.
important to somehow track back? And do we do that in some way in Canada now, or how does that work?
I don't know actually if that's done right now, and I don't know if there's anyone here from living donor programs, because you're right, it's not something that we do very much with lung.
Yeah.
But you're right, it is an important point, right? In that if there's something that's detected, and say it's only maybe say a year after transplant, how does that relate in terms of understanding the risk to the recipient? And so it's an important thing, and I'll definitely, working with some of the groups involved with CTR, I'll actually ask that question because it's a good one.
Oh, okay, thank you.
Thanks, Dan.
I don't want to put any of the renal physicians on the spot at all, but the renal physicians might be in a good place to answer that. Is there any feedback that you guys receive when a living donor has a cancer diagnosis, maybe early after donation?
Could also ask, I know the ATI working groups include living donations, and I'm involved in the living donor one, so I can ask that question there too.
That's great.
Yeah, and this is Sandra. In my experience, the living donor program, if they're notified of a post-donation malignancy in the living donor, will actually reach out to the recipient physician so that we can have a conversation, evaluate what the risk is to the recipient and have a conversation and determine a follow-up.
And that's only if it comes about as information. There isn't sort of like an ongoing screening process or whatnot for that for donors.
No, the living donors, I think many of them are followed. They're all seen at 1 year post-donation unless they were evaluated elsewhere, and then that program would do their 1 year follow-up. And then at that point, they're given an option of either ongoing follow-up annually or biannually through our kidney clinic, or returning to their family doctor to have those annual tests done. And so that's sort of negotiated. The living donor program leaves, they disappear from the care team of the previous living donor after 1 year. Mm-hmm. So it really becomes the nephrologist's responsibility if they're going to continue to follow the patient. But, we don't complete the annual screening for cancer, and or every 3 year, whatever is recommended by the public health guidelines. Mm-hmm. So whether we become aware of those issues, and the further out they are from, in diagnosis of cancer from when they donated, it becomes less and less relevant to the recipient.
Right, I agree with that.
I think we're sort of running out of time. Trish, you had raised your hand briefly. I don't know if you just had a similar comment or if there's any additional comments you had.
Yeah, no, it was just if nobody else from renal was around, I was just going to basically say what Sandra did. But all good. Thanks a lot, Alim. Great talk.
Thanks, Trish.
Great. And Murray just had a final comment to say, great research, keep it moving. Need to integrate this into complete donation, transplantation, clinical admin processes. And great presentation. Glad you can speak quickly.
Yeah, cover a lot of ground.
So I just want to close. Saida has put in the chat as well. Next Wednesday, we won't have a seminar because the CDTRP annual meeting is happening December 7th to 9th, and the registration link is there. And then on December 12th, which I think is a Monday, it's a little bit unusual, we'll be hosting Dr. Rafael Correa Rocha, who will be doing a combination sort of in-person hybrid Zoom presentation on first clinical trial to prevent graft rejection in heart transplant children employing cellular therapy with autologous Treg obtained from thymic tissue. And the registration link is also in the chat. So thank you, first of all, to Dr. Hirji for an excellent presentation and a great discussion. And thanks everybody for joining, and we hope to see you at the CDTRP meeting and then on December 12th.